hodology, and I did not know this word till a few years back, and it's actually study of pathways. And I thought it's an interesting word which I can use in the on the medicine side. And because cerebellum, as you know, is an organ which is a structure which is very well connected to other parts of the brain and the neural system. So they say, one picture is worth thousand words. This is true over here. We see these pictures in the reading room every day. This is a young kid with Sturge-Weber syndrome, left cerebral hemisphere. You can see is atrophied because of the Sturge-Weber syndrome. But how many of us notice that the right cerebellum is also atrophied, right? It's a cross connection. We call it cerebellar cross diaschisis, and that's what this picture is showing. So what I'm going to talk about in the next 35, 40 minutes is cerebellar anatomy, the cerebellar pathways, cerebellar function. Most of us in medical school thought cerebellum is all about motor coordination. That's not true, and I'm going to talk about that. And then brainstem and cerebellum and other parts, cerebrum, they are very well connected, and we see a lot of cases where you could see that correlation and the connectivity very clearly on the clinical cases. I'm going to try to show some of those. So, some of the fun facts, anatomical facts about cerebellum. Cerebellum forms 10% of the brain mass, but it contains almost 80% of the total neurons. You will be surprised to know that there are 80 billion neurons in cerebellum versus 20 billion cerebrum, right? So that is there. Sorry. And there are more connections to other parts of the brain than any other brain structure. So that's very, very important to know. And that's where the word hodology comes from. And then just to give you an idea, lateral aspect of the cerebellum undergoes enormous growth, which kind of parallels evolutionary growth of the prefrontal cortex during the language development, right? So that kind of tells us cerebellum is so important, not just motor, but emotion, cognition, language, and that's what I'm going to talk a little bit. Uh, there are three fissures in the cerebellar anatomy. You have the primary, horizontal, and the posterior fissure. Again, many of us don't talk about that in our radiology reports, and I hope some of you start putting that in your reports. There are three surfaces. Again, tentorial is the superior surface of the cerebellum. Lateral is the petrosal portion, and then the posterior surface is also known as the suboccipital surface, as is very well, closely associated with the occipital bone, right? And there are three anatomical lobes, anterior, posterior, and flocculonodular lobe. There are three functional components or the lobes of the cerebellum. Again, we don't put that in the reports or discuss that. The spinocerebellum, which is the median and the paramedian portion, the cerebrocerebellum, which is the lateral portion, and then the vestibulocerebellum. We'll talk a little bit about that. There are three cortical layers, interestingly, molecular, Purkinje cell, and granular. So these are the three fissures. So some of these are taken from the internet, and you can see, this is the anterior lobe of the cerebellum, which is separated from the posterior lobe. The biggest portion is the posterior lobe by this fissure called the primary fissure, right? And then there's another fissure, posterolateral fissure, which kind of separates the smallest portion of the cerebellum, which is the flocculonodular lobe. And this is, again, just a representation, kind of coronal representation. Vermis is in the center. We usually talk about the vermis and the cerebellar hemisphere. And then you can divide, the cerebellum, the vermis, and the cerebellar hemispheres into anterior, posterior lobes, and the flocculonodular lobe over here. Cerebellum, interestingly, is also divided into 10 lobules, and these are named, even the vermis and cerebellar hemispheres, both. And they have names, and they have also are numbered 1 to 10, right? And again, sometimes it's very difficult to use these names or remember them, but, try to remember some of these. For example, I have started using Cruz 1 and Cruz 2 in my reports. The cerebellar tonsil is the most common, accepted terminology which we use again in our reports. But the rest we typically say, superior cerebellar or posterior cerebellum, right? We don't really differentiate that much. Again, another representation, 3D surface shaded display showing you the anterior surface of the cerebellum and the posterior surface, and then you can see the primary fissure and the horizontal fissure kind of dividing the cerebellum into different lobes. As I said, there are three functional lobes of the cerebellum. The spinocerebellum, which is the portion, the median and the paramedian portion of the cerebellum, which is connected to the spinal cord very well. The cerebrocerebellum, the lateral portion, the phylogenetically the newest part of the cerebellum, is connected very well to the cerebrum. That's very, very important. And then the phylogenetically, the oldest portion of the cerebellum is your vestibulocerebellum, again, involved with the vestibulocochlear functions, right? There are three pairs of deep nuclei. We typically only talk about dentate. The other two are very small, and we'll talk a little bit about those. There are three pairs of peduncles. Most of us do know the cerebellar peduncles, which are basically either bringing in information into the cerebellum, so they have the input, or the afferent fibers coming into the cerebellum. For example, the middle and the inferior peduncles are mostly afferent, bringing in afferent fibers, and then superior cerebellar peduncle is mostly output or efferent fibers. There are three vessels which supply the cerebellum, vascular supply. The superior cerebellar artery, pica. These are branches of the basilar and the vertebral artery. We all know very well. We do see these infarcts in the cerebellum very, very often in clinical practice, right? This is a patient with a superior cerebellar artery infarct. You can see the territory, the superior part of the cerebellum is involved. That's your ICA. ICA infarcts are much less common. They can also involve the middle cerebellar peduncle, some of the ICA infarcts. And then the pica infarcts are probably the most commonly we see in the cerebellum. And then, of course, I'll talk a little bit about Wallenberg syndrome, dorsolateral medullary infarct, which is part of the pica territory, a little bit more in detail. So cerebellum is connected to the brain and the spinal cord through these peduncles, the three pairs of peduncles, which are very, very important, bringing these pathways or the fibers to the cerebellum and then taking it out, the information out. So superior cerebellar peduncle is the major output pathway. It's the most efferent fibers which originate from the dentate nucleus and then in turn kind of project to the midbrain structures, including the red nucleus, the ventrolateral, ventral anterior nucleus of the thalami. So basically, a lot of connections from the cerebellum through the dentate into the midbrain and the thalamus. And then afferent fibers, some of them, it's predominantly efferent output, right? But there are some afferent fibers which are coming in from the anterior spinocerebellar tract that are conveyed to the anterior cerebellar lobe via this peduncle. And this is a very nice paper talking about tractography and how it demonstrates this very, very important pathway from the cerebrum to the cerebellar. It goes from one side to the contralateral side, and I'll talk a little bit more in detail about that. That's very, very important, and we need to understand that. And once you understand it, you will start seeing changes in the cerebrum and the cerebellum in many, many disease processes. So the first peduncle we're going to talk about is the superior cerebellar peduncle. These are 3 Tesla images. These are 9.4 Tesla images taken from Dr. Nidek's work on a cadaveric brainstem, just to show you where the superior cerebellar peduncle runs. And again, these are slightly zoomed in, so you may not understand, but let me show you a case. This was actually during the COVID pandemic. We had this case with ocular bobbing and fast down and up, slow movements of the eyes. And these are diffusion images. We still don't know why this patient had these changes, but it was a good example to show you where the superior cerebellar peduncle and the decussation is, right? Many of us see this bright signal in the midbrain very often, and I have seen this being called an infarct also, especially in older individuals. This is not an acute infarct. This is basically your superior cerebellar decussation, right? And you can see the fibers kind of crossing, and this is where your superior cerebellar peduncle is, exactly right there, right? So that's where you have the superior cerebellar peduncle, and then you can see these fibers going to the dentate nucleus, right? That's your dentate nucleus over here on the contralateral side, and you can see again. I'm gonna go back one more time just to guys give you a flavor, where you can see the superior cerebellar peduncle decussation and the fibers, right? So that's your superior cerebellar peduncle. Okay. So dento-rubro-olivary pathway, again, this is very, very important pathway. We talk about this because we see these changes, any kind of lesion. This is basically, the entity known as hypertrophic olivary degeneration. Inferior olivary nucleus kind of undergoes this hypertrophic degeneration, and these are resultant from a lesion anywhere along this triangle. This triangle is formed by the dentate nucleus, which is connected to the contralateral red nucleus, to this superior cerebellar peduncle, as we looked at that, the fiber tract. And then this red nucleus is connected to the same side, inferior olivary nucleus, through a tract called central tegmental tract. And then the dentate to the contralateral inferior olivary nucleus is connected through the inferior cerebellar peduncle. So superior cerebellar peduncle, central tegmental tract, inferior cerebellar peduncle, and this pathway, this triangle is called Guillain-Barré triangle. And any lesion along any of these structures will cause hypertrophic olivary degeneration of the inferior olivary nucleus. So I'll show you some cases, how this works. It's basically a transsynaptic degeneration resulting in vacuolation of neurons and increased glial cells demyelination, and then eventually they will shrink. So this is a case over here. This is a case, an old case which had a dissection of the basilar artery as over here, and resultant from that had a paramedian pontine perforator infarct. I was reading this follow-up study, which was old infarct by that time. But this, you could see there is a lesion in the inferior olivary nucleus, right? So how do we connect these two things? Patient having a paramedian pontine perforator infarct from a basilar artery dissection. This is because of this lesion affecting the central tegmental tract, part of that triangle we talked about, right? And it's on the same side as the red nucleus. So this will cause the ipsilateral inferior olivary hypertrophic degeneration. And that's where, the lesion is roughly over here in the central tegmental tract. And if you remember this triangle, Guillain-Barré triangle, you see why this lesion affecting the left central tegmental tract is causing injury and inferior olivary hypertrophic degeneration, which typically you don't see immediately after injury, but it takes a few weeks to a couple of months before you start seeing these inferior olivary hypertrophic degeneration changes. Another case with an abscess in the brainstem. These are not very common, right? This one turned out to be an abscess, was drained, with a needle, image-guided needle drainage, and then was treated with antibiotics. So you can see the abscess kind of clearly resolved. All you see is a tiny little dot of enhancement 2 months later. But 2 months later, the patient developed another lesion in the inferior olivary hypertrophic degeneration, kind of from the same side, the ipsilateral, the left central tegmental tract injury because of this abscess causing inferior olivary hypertrophic degeneration. Okay. Another case with a midbrain glioma. Again, I'm not talking about gliomas over here, but the reason I'm showing you this case is this patient had left inferior olivary hypertrophic degeneration, and that's because of injury to the red nucleus, right? So this glioma was affecting the red nucleus, involving the red nucleus, and that's how it led to this left hypertrophic olivary degeneration. We also see some cases of bilateral inferior olivary hypertrophic degeneration. If you see, this patient had a cavernoma in the midbrain, right? So there is a cavernoma, large cavernoma in the midbrain, which led to this bilateral inferior olivary hypertrophic degeneration. You can see the changes are brighter and more on the right side than the left side. And this is because of this lesion affecting the brachium conjunctivum or the superior cerebellar decussation. So if you remember the COVID case I've shown you, there was bright signal which was running through the fibers and the decussation. You can see this lesion is kind of affecting the right here, the yellow is your brachium conjunctivum, and this lesion is kind of damaging that. And that's the reason it's affecting both the triangles, right? And that is the reason you have bilateral inferior olivary hypertrophic degeneration. And if you can take something away from this lecture, this is one of the most important diagrams I'm going to be showing you probably. The cerebrum on one side is connected to the contralateral cerebellum by this circuitry called cerebrocerebellar circuitry. And there is no monosynaptic connection between the cerebrum and cerebellum. So the cerebrum, the neurons, kind of axons, they kind of, the connections terminate in the pons, and then they go through the middle cerebellar peduncle to the cerebellum, contralateral cerebellum, right? So these are the afferent fibers coming from the cerebrum, decussating in the synapsing in the pons, and then going through the contralateral middle cerebellar peduncle, which we already talked a little bit, and then going to the cerebellum. And then the neurons and the axons originating from the cerebellar cortex, they kind of synapse in the dentate nucleus on the same side. And then the fibers from here, the connections from here, go through the superior cerebellar peduncle, right? Superior cerebellar peduncle is mostly the output pathways, the efferent pathway, right? This middle cerebellar peduncle is mostly afferent or input. The superior cerebellar peduncle is that's where the decussation, and then they synapse in the red nucleus in the thalamus, and then from there the connections go back to the cerebrum, right? So that completes this communication of the cerebrum with the cerebellum, which is very very important cerebrocerebellar circuitry over here. Sorry, missing the cartoons over here. So you can see these connections going back from the cerebrum to the contralateral cerebellum and then back to. So this is one of the very good DTI tractography papers which talks about these cortico-pontocerebellar pathway if somebody is interested in looking at it. But again, just to show you the cartoons one more time, these are different peduncles, and you can see the middle cerebellar peduncle is mostly afferent, bringing in information and pathways from the cerebrum. Inferior cerebellar peduncle, we'll talk a little bit more about that. It's mostly an afferent to cerebellum from the spinal cord. And then the superior cerebellar peduncle taking out the information from the cerebellum through the dentate to the contralateral cerebral hemisphere. Again, these cartoons again show you the same thing as I talked. I'm just emphasizing the point again to make sure we understand this correctly. And this is another case, where you have kind of chronic injury to the right cerebral hemisphere. This patient had Rasmussen encephalitis and intractable seizures. What you see over here is the atrophy of the right cerebral hemisphere. But notice the left cerebellar is atrophied because of this injury, which is bringing in these excitatory pathways, and those excitatory pathways are no longer there. You can see the cerebral peduncle is small on this side. Cerebellar, the middle cerebellar peduncle is small on the left side. That's where the afferent pathways are going to the contralateral cerebellum, right? So we know this entity very well, cross cerebellar diaschisis. So middle cerebellar peduncle is composed entirely of the afferent pathways, cortico-pontocerebellar tract, or the fibers which start from the cerebral cortex to the pons. And these fibers bring in sensory motor areas of the cerebral neocortex and make the middle cerebellar peduncle the largest of the three cerebellar peduncles, right? So again, just to show you on a 3.4 Tesla, a 3.5 Tesla clinical MRI and a 9.4 Tesla cadaveric brainstem images from Dr. Nidek's work, you can see the middle cerebellar peduncle. That's where the biggest of the tracts going from the cerebrum into the cerebellum, right? And this is why cross cerebellar diaschisis occurs. It's just a cartoon showing you any insult in the cerebral hemisphere will disrupt these pathways, which are excitatory in nature. So that excitatory signal is missing. And that's the reason it leads to cerebellar hypometabolism and cross cerebellar diaschisis, right? So we see that atrophy on anatomical images very often. And I'll show you now some very interesting cases. And if you pay attention to your physiologic imaging, you will see this more and more. This is an older individual with right leg stiffness and forgetfulness. We were trying to see if there is anything in the left precentral gyrus in that Rolandic, perirolandic area. Hardly anything on the MR images. We have a MRI PET for many, many years, and we do these patients undergo MRI PET scans, and you can see the PET. Red is more metabolism, blue or green is less, and you can see there is hypometabolism in the left perirolandic region, kind of corresponding to what the patient's complaints are, right side motor weakness going on, right? So that is the hypometabolism over here. But how many people and then you go back and you say, maybe this sulcus is a little wide, right? So there is some atrophy, very mild atrophy structurally going on. But how many people notice the cerebellum, the contralateral cerebellum? Look at this is so hypometabolic, right? And again, this we see very often on the MR PET or the PET scans. And then you go back and you say, wow, yeah, the right cerebellum is a little bit shrunken, right? So you can see, even though structurally it may not be very obvious, functionally it's very obvious that these two paths, these two structures are connected. And there is hypometabolism of the brain in this left perirolandic region corresponding right cerebellar hypometabolism on the FDG PET. And once you start noticing that, you will start seeing more and more. We do a lot of CT perfusion for stroke work and other works. This is a patient who had a intracranial infection, which was being treated, and then developed seizures which were localized to the right cerebral hemisphere. And he underwent CT perfusion to rule out an acute stroke. We didn't see acute stroke, but we did see seizure-related hyperperfusion in the right cerebral hemisphere, kind of corresponding to the left symptoms he was having. On the CBF and CBV maps, you can see clearly hypermetabolism, which can happen with patients who have seizure-induced changes. We know that. But look at the contralateral cerebellum, right? Again, look at the contralateral cerebellum. There is hypermetabolism on the right side, right cerebral, and there is hyperperfusion or hypermetabolism, probably reflecting, hypermetabolism in the left cerebellar hemisphere. I call it functional cross cerebellar diascasis. So even though the structurally, they may not be atrophied or you may not see changes, but functionally you will see changes. Another case over here is the patient with acute left MCA stroke. Again, once you start seeing one case, you will start seeing more and more, right? This patient had a left MCA acute stroke. These are CBF, CBV maps. This patient was having an area of ischemia and increased mean transit time in the left frontal opercular region corresponding to this left MCA stroke. But look at the right cerebellum, right? Again, beautiful case showing you that there is hypoperfusion and increased mean transit time. Again, not very subtle changes, but once you know where to look, you can see these changes fairly often. This was one of the most dramatic cases I've seen. This patient had seizure-induced. This patient had a subdural hematoma, which was drained along the right cerebral hemisphere and left side, and he developed seizures. And the seizures were somehow localized to the right cerebral hemisphere. These are diffusion-weighted images. You can see the seizure-induced changes. This was not acute stroke. These changes reversed over time, and these were acute changes at the time the patient was having a seizure. And then you can see the left cerebellum. Not a vascular territory. This is not one single vascular territory. This is not acute stroke. These are just diffusion changes because of the hyper-functioning right cerebral hemisphere because of this seizure activity going on. And then this left cerebellum also somehow showing very bright signal diffusion restriction corresponding to the cross. As I said, I call it functional cross-cerebellar diascasis because of this excitatory, or the disruption of some of these corticopontocerebellar tracts, right? Again, another case over here. Again, I'm not showing you a tumor case, and even though I love tumors, this is a pilocytic astrocytoma centered right in exactly where the left middle cerebellar peduncle is, right? So this is a kind of a chronic or slow-growing benign tumor, right? Has been there for probably a few years. And you can see the right middle cerebellar peduncle. You can see the left middle cerebellar peduncle. And what do you see over here on the rest of the images is an example of left cerebellar atrophy. You can see the left cerebellar hemisphere distal to this tumor, and the middle cerebellar peduncle is atrophied because the fibers which are bringing in information from the right cerebral hemisphere through the left middle cerebellar peduncle into the left cerebellum are disrupted by this tumor, right? So you can see this beautiful, again, atrophy because of disruption of this cerebellar circuitry. And then again, cross-cerebellar diascasis because of that. Another case which will take us to the next cerebellar peduncle, inferior cerebellar peduncle. This is a patient who had a low-grade tumor, almost like a pilocytic astrocytoma in the right dorsolateral medulla, right over here. And again, I'm not showing you the lesion for the tumor, but what this tumor is causing. And again, as I said, this was patient with a kind of a low-grade tumor, which was there for many months and years, had headache, dysphagia, hoarseness of voice, right vocal cord paralysis, corresponding to the vagus nerve nucleus injury over here from this tumor. But that does take us, where is this tumor located? This tumor is located exactly where the inferior cerebellar peduncle is. Again, 9.4 Tesla images of the medulla. You can see the medullary pyramid, the inferior olivary nucleus, and that's the bump, the posterolateral bump of this medulla is called the inferior cerebellar peduncle, which brings in information from the spinal cord into the cerebellum, right? So inferior cerebellar peduncle, it's mostly an afferent pathway, afferent structure, which is bringing in information from from the spinal cord, brainstem, and also the cerebral cortex into the cerebellum. And interruption of any of these pathways, afferent pathways, can result in atrophy of the cerebellum. Again, just a very quick kind of cartoon diagram. This is not exactly where the olivocerebellar fibers run, but remember we talked about the Guillen-Murray triangle, how inferior olivary nucleus from one side is connected to the contralateral dentate. That's through this inferior cerebellar peduncle. Again, not a very anatomical description, but just a cartoon how these fibers run. And then these are the other fibers. Again, not accurate description, just a diagrammatic cartoon to show you that there are spinocerebellar fibers, there are reticulocerebellar fibers, there are vestibulocerebellar fibers, which connect the structures in the brainstem, lower brainstem, or spinal cord with the cerebellum, right? And these are all these tracks are running through the inferior cerebellar peduncle, very, very important structure. But the reason I wanted to show you this case is not because of the tumor, but because of the atrophy it is causing. Again, if you know where to look, you will see there is a little subtle atrophy of the right cerebellum, and that is happening because this tumor is disrupting these afferent fiber tracks, very similar to the previous cases I've shown you, creating this kind of injury. And the cerebellum, distal to that injury, because there is information, these pathways are disrupted, atrophies, right? So again, when you see a lesion anywhere in the brainstem, anywhere in that region, look at the cerebellum closely, and you will see these changes over time, occurring in these cases. And one thing I always struggled with in medical school is what is Wallenberg syndrome? What are the things which are, 10 different signs and symptoms associated with it. It's a very well-known syndrome, lateral medullary infarct. This is an example over here. This patient had a right vertebral artery dissection, a young female who had ataxia, hiccups, and neck pain, ended up developing this right dorsolateral medullary infarct right over here. And, very clearly shown to involve the inferior cerebellar peduncle. But this is a 9.4 Tesla image again from Dr. Nidek's cadaveric brainstem work. You can see this image looks like almost like a histopathology section. It shows you all these structures beautifully. Medullary pyramid, you have the inferior olivary nucleus. What we are interested is in what is happening in this region, the dorsolateral medulla, which is supplied by the pica, and that's the reason of this infarct. And what does Wallenberg syndrome constitute? And once I knew all the structures in this region, it's very, very becomes easy to understand how these signs and symptoms. For example, the injury in this region involves the inferior cerebellar peduncle, and that brings in these fibers. So that leads to cerebellar signs, including ataxia, dysmetria, dysdiadochokinesia, right? So that's one thing. The spinothalamic tract, again, in this part of the dorsal brainstem, involves contralateral pain and temperature sensory loss from the body because of involvement of the spinothalamic tract, because spinal trigeminal nucleus is involved. So there is ipsilateral pain, temperature, sensory loss from the face, because the vestibular nuclei are involved. So there is vomiting, vertigo, and nystagmus in these patients. Because nucleus ambiguus is involved, that's the reason patients have ipsilateral, laryngeal, pharyngeal, and palatal hemiparalysis, dysphagia, hoarseness, diminished gag reflex. They may not have all these signs and symptoms, but a complete Wallenberg should have some of these, right? So central tegmental tract, remember, the tract which connects the red nucleus from the same side with the inferior olivary nucleus. If you disrupt that, it will cause palatal myoclonus. We saw a few cases of that, inferior olivary hypertrophic degeneration. And then the patient may also have ipsilateral Horner, because there are descending sympathetic fibers in that part of the brainstem also, right? So if you combine all that, if you look at these structures very, very closely, you will know why Wallenberg syndrome, complete Wallenberg syndrome, has all these signs and symptoms. Just a word about the vascular anatomy of the medulla, because we're talking about that region. The medulla, the paramedian portion, is supplied by the anterior spinal artery, which is a branch of the vertebral artery. The dorsolateral part is supplied by the pica. We discussed that, the Wallenberg syndrome. In between these two territories, there are direct perforators from the vertebral artery, which supply this part of the medulla. And then the posterior part of the medulla is supplied by the posterior spinal artery. right? So these are the major arterial branches supplying the this part of the medulla. So let's jump on to the cerebellar function. As I said, we always learned in the medical school that it's a big motor coordination structure which is at the base of the brain, but nobody taught us more than that. And I learned very late in my life over here that there is a non-motor cognitive function to the cerebellum, which is very, very important. Again, once you understand that, you will start seeing cases, examples of those in your clinical practice. And if you want to know a little bit more about that, there is work from Dr. Jeremy Schmamam. He's a neurologist in Boston and Harvard. He is the one who has done most of these very beautiful papers about the role of cerebellum beyond the motor function, into cognition and emotion. So if you want to read more about that, so cognition, cognitive functions, emotional, and language. Language is very, very important. Again, very well connected to the cerebellum from the cerebrum, and these are cognitive functions. These executive functions, visuospatial, affective, and linguistic. Right? These are all. And where are these located? So if I show you just a coronal cartoon, you have the median and the paramedian structures. Most of the cognitive functions are involved in the lateral part of the cerebellar hemisphere. Motor is in the paramedian portion, and then emotional is your wormus, right? How do we know these things? Because we have been doing a lot of functional studies, including task-based and resting state functional MRI studies. Again, this is another article, image taken from another article, which shows you, these task-based and resting state functional MRs can show you where the motor strip is. Of course, we all know homunculus upside down, the foot, hand, and the face laterally represented over here. But did you know that the cerebellum, the same areas are represented in the cerebellum in a exactly very similar fashion, close to each other, in the anterior portion of the cerebellum, for example, in the anterior lobe, the motor functions, and the motor functions are more in the paramidline structures, right? So if you remember from previous cartoon, these are again, another cartoon showing you how the function is kind of divided. More laterally you go, you have cognition. Medially, you have more sensory motor in the cerebellum. One more thing I learned fairly late is so again, these are 10 lobules of the cerebellum. Again, these are numbered 1 to 10. They are also named. For example, this one is Crus 1 and Crus 2, which are the lateral most portion of the lateral cerebellar hemisphere, the lobules, which are very well connected to the prefrontal Broadman area 46. Why I'm stressing on that? Because these are the areas which are involved in language, right? So you can see language is not just cerebrum. Language is very complex to understand, but it's very well connected to the cerebellum into these areas called Crus 1 and Crus 2. Another very good study from the same paper, this is a review article, very nice review article if you want to read about that, is showing you that these are resting state functional resting state functional maps, which show you the connection of the cerebrum with the cerebellum. And you can see these blue areas, which are your sensory motor. They're connected to these blue areas, which are median and paramedian in the cerebellum, right? And then more laterally, you have your the executive network, or in orange, and then you have your default mode network more laterally in these red maps over here, right? So again, just to show you, how cerebellum is very well connected, kind of similar functions which are represented in cerebrum, they are represented in the different portions of the cerebellum. Now, going to the deep nuclei of the cerebellum, there are three pairs, as I said. You have the fastigial, very small nuclei. We hardly talk about this. The only nucleus we know and we talk about in clinical practice and in our reports is the dentate nucleus, which is the largest of the cerebellar nuclei. And then the third one, which is actually two nuclei combined together, known as interpose, globose, and emboliform. Again, these are very small nuclei. They are more in the paramedian portion of the cerebellum. How are these connected, and how are these involved in the different functions of the cerebellum? Again, more midline structures They are more motor, more emotional, and then motor and cognitive, and that's how it is. So use fastigial, which is the closest to the midline. The small nucleus gets output from the vermis, and it's more involved with the more emotional component of your um, functions. Interposed gets output from the intermediate nucleus, and then it's the motor part of your function. And dentate, which is the lateralmost, the largest cerebellar nucleus we fairly well know and see, is involved in the cognition. How is that important? Just to wrap up very quickly with a couple of clinical cases. You have these patients, young patients. This is a young female, has a medulloblastoma, very classic tumor in the fourth ventricle. We all know, very well restricting on diffusion, hypercellular, almost in the midline. These patients undergo surgery to debulk this tumor, and then post surgery, MRI looks great. You have complete resection. One of my neurosurgery friends and mentors, he used to say, if MRI looks very good, usually the patients don't look that good, unfortunately. And this is what happens in these patients. The surgeon is doing a great job by taking the tumor out completely. What you see is some injury, devitalized tissue, infarcts in the cerebellum, which happen because this tumor is in a location like that, difficult location uh, to kind of take care. So, but these patients, sorry, let me go back. I'm sorry. These patients develop a lot of problems, including emotional lability, right? And also, sorry, this is the second case. This was the case we were discussing, right? They develop a lot of motor and cognitive issues post surgery, and this is called cerebellar mutism. Also, another case, another medulloblastoma tumor, which was taken out in a young female 3-year-old, and this is post-op. Again, you can see the complete resection of the tumor, but these patients end up doing very poorly after surgery. Sometimes they have a lot of motor, emotional, cognitive issues because of this injury to these dentate nuclei and these tracks. Remember, again, these cerebrocerebellar tracks and these connections, which are bringing in information into the cerebellum. So you see that, this cerebellum is not just motor coordination, it is a lot of cognitive functions, a lot of emotional, and also language, linguistic functions. These are all connected, and they are connected. And that reason these patients end up developing these issues, also known as very well known syndrome in these patients with cerebellar mutism after surgery in that region, is because of disruption of these cerebrocerebellar tracts or dentorubro-thalamic tracts. Again, language, as I said, many of these patients also develop language issues because this language, cruise 1 and cruise 2, we already discussed, is very well connected to the prefrontal Broadman area 46. So with that, let me just summarize. I hope I gave you guys a little flavor of the cerebellar anatomy and hodology. Hodology is basically study of pathways, and just a fancy word to start a conversation. Rule of three. If you remember, we talked about three lobes, three fissures, three functional lobes of the cerebellum, three pairs of nuclei. Everything you can count in three. Vascular anatomy, you have three vascular. But the most important thing, if I want you to take away from this lecture, is that remember these cerebrocerebellar circuitry, very very important. We forget this, but if you remember this and know the pathways, you will start seeing a lot of cerebral lesions causing cerebellar atrophy, or brainstem lesions causing cerebellar atrophy and cerebellar dysfunction or functional cross cerebellar diascasis. And function, as I said, cerebellum is not just motor; it's very very important in cognition, language, emotion. So that is something, again, Dr. Jeremy Schmauman's work and others have shown us beautifully. And with that, I want to thank some of the people who contributed some slides, cases, and some information about this, especially Dr. Nidek's, 9.4 Tesla images, which I've used just to illustrate some of these very small structures in the brainstem and the cerebellum. All right, I'm going to stop sharing my screen, and let's see We have, I think I saw a few hands raised and questions. Happy to answer those.
Yeah, but before we go to the Q&A, so everyone do put your questions on the Q&A. But I must say one thing, Dr. Jain, that hodology is the pathway, right? It's the study of pathways, and I think you showed the pathway to becoming a good neuroradiologist because it ultimately is in the study of pathways. I think that's one take home even for a non-neuroimager to understand with me that you have to go back to the basics to really understand everything that you're seeing on the screen. So this was
Absolutely. Absolutely, it took me many, many years. I never understood these pathways and the connections in my anatomy classes in the medical school, but I learned these many, many years later. And then you say, "Wow, these are connected." Yes, this was there. We did discuss, we did read about it, but never understood. But thank you.
and I mean, before going to Q&A, I think a lot of comments already coming, and Bethlehem is saying simply mind blowing. Thank you so much. Great session. Um, so anyway, let's go to the questions. So an anonymous attendee is asking, can a lesion in the cerebellum cause cerebral atrophy? Oh, that's a very interesting
Yeah,
question.
that's a very good question, and I've been thinking about it, and I've been looking for a case like that. And I'll tell you, I just saw a case 2 months back where a cerebellar dentate nucleus injury actually led to the contralateral thalamus being a little small. So again, we don't look at the thalamus, or we don't measure the volume and the size of these areas very closely. But I did see a case recently. I have it. Maybe I should put a slide. And it is tough to convince someone, but I saw the dentate injury on one side causing the thalamus to be small on the other side. I don't know if it's connected, right? I have not, still have to see a case of cerebral atrophy because of cerebellar injury. I have not seen that. I think there are some cases where you could question that. But then again, the question becomes is the cerebral is the first one to get injured or the cerebellum? But I did see a case recently where dentate nucleus injury on one side caused some very subtle atrophy of the thalamus. Again, if I show it to 10 people, five may agree and five may not agree with me. But yes, absolutely. Keep looking. If you have a case, send it to me, please.
Indeed. Kavan is asking, why don't we see cross cerebellar diascisis in all cases of unilateral large infarcts or atrophy?
That's again a very good question. I think you do have the injury, and you may not have structural changes yet, or not enough structural changes yet, right? If you wait enough, you might see, and that's the reason I shown you these functional cases, right? Whether it's PET, CT perfusion, or diffusion, you do see these structural, functional changes happening, metabolic changes happening over time in a acute phase, of course. But over time, I think there are some structural changes. And again, if you look carefully, you will see very subtle changes. I think unless until we start doing volumetric for every location, you may not see very subtle differences, right? If it's a 5-10% change in volume of the middle cerebellar peduncle, you may not appreciate with an, with the eyes only. But I think you keep looking, you start looking. Whosoever asks this question, you will see more cases in actual clinical practice.
Amber has written enlightening topic, lots of new ideas. Yasir has asked the connection between the substantia nigra and dentate nucleus and disease can involve both at the same time. Sure.
Yeah, absolutely. There are a lot of neurodegenerative conditions which cause that, and deposition again. Iron deposition in neurodegenerative conditions, happening in both these structures is very well known, right? So again, just keep looking for these connections. You will find more associations, more things.
Madhu has asked whether we should mention the pathway involved in the report. Do you do that?
Yeah, I do. I do. I've started saying that in my reports that it's probably disruption of these corticopontocerebellar circuitry that you are seeing changes in the cerebellum. I have started to use uh, those complete sentences in my reports because many a times we see these low grade tumors and nobody mentions the cerebellar is atrophy, right? For example. So I have started to put an explanation for that so that they don't think it's a cerebellar direct injury to because of something.
Bethlehem is asking what is the trick to be meticulous in evaluating a scan on a 1.5 Tesla MRI. Is there any search pattern that you use to search for these pathways and the related atrophy?
Everyone has their own way to look at things. Uh, uh, one of the things I learned very early on is if you don't know, you will never see, right? And if you know something is happening, you know these pathways, you will look more, right? And so I bet you will start seeing these changes on a 1.5 Tesla also, because now you know about the cerebrocerebellar circuitry. There is no trick, this is just you have to create a checklist. We are using a lot of template reports, right? The reason for going to template reporting is the same thing, that you look at all these structures in a manner where it's meticulous and you're not missing some things. Yeah, create your own path checklist and create your own. You will do it, over the years. Yes.
So since we have time, this is an anonymous attendee who just requested you to explain the left pilocytic astro causing changes in the left occipital area again. Generally
Yeah,
we don't.
it was not left occipital lobe. It was the cerebellum. I think I may not have been very clear on that slide, but it was the cerebellum, not the occipital area.
I think someone is requesting again anonymous to see the first slide of the triangle and the nuclei forming it.
Okay, let me see if I can find it very quickly and I can share my screen. Um, yeah, that triangle is one of my residents many years, who's a faculty. He drew that a cartoon for us, part of a exhibit we had at RSNA. This is probably good 15 years ago, but let me see if I can slide share again. Share my screen. So here we go, right? So this is the triangle, and it is there in many articles. You will see people have drawn this. So this is the midline, dotted line over here. This is the Guillain-Barré triangle. You have the red nucleus on one side connected with the same side inferior olivary nucleus, and then the contralateral dentate. How are these connected? So this red nucleus is connected to the inferior olivary nucleus with the central tegmental tract. This red nucleus is connected to the contralateral red nucleus through the superior cerebellar peduncle. And then this contralateral dentate is connected to the ipsilateral inferior olivary nucleus through this inferior cerebellar peduncle, right? So that forms the triangle lesion in any of these triangle endpoints or triangle arms, we call it, right? And that will lead to injury to that inferior hypertrophic olivary degeneration of the inferior olivary nucleus, whichever side it is, right? So these are and then there was another one which showed triangles on both sides just to complete the story here. So just to show you these two triangles, right, how they are connected, just cartooning. You will find better examples on the Google or in the internet for sure.
Ulla is asking what was the pathology on the abscess in the brainstem?
Oh, I'm sorry, I don't know, remember the bug. It was probably just a regular streptococcal pneumonia or something. It was just an abscess. The reason to show that case was that the injury to the central tegmental tract, which led to inferior olivary hypertrophic degeneration. Yeah.
One is asking in lesions of GMT, why does only the inferior olivary nucleus show degeneration? Why not the other two?
That's a good question. Because of these, the inferior olivary nucleus has these neurons which vacuolate, right? And that is the reason we see maybe there are changes happening in the red nucleus also in the dentate, which we're not very good at seeing. Maybe we should start looking at the MRI a little more closely, or maybe we'll have some more sequences, better sequences, which will show. Right now, the T2 and the FLAIR show those edema and the hypertrophy of the inferior olivary nucleus easily. So that's the reason I think we see. I bet you there are changes happening in the substantia in the red nucleus and the dentate also, which we're just not able to see. Very good question. Yeah.
Um, this is anonymous attendee, does the cerebellar changes due to cerebral lesion reflect in the sense that there are clinical symptoms in the patient? Or can that be
Absolutely. 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 That's where you need to read Dr. Jeremy Schmaman's work. He has a lot of very good case series also published. Again, there is really no way to do, like a randomized trial kind of thing, but these are very great case series where he has discussed clinical cases and how one lesion affecting the function, right? So I think if you Google and search on the PubMed, Dr. Jeremy Schmann's, there's a great. I had another slide. I took it out. I should have probably kept it. Is one case series where it has clearly shown that the patient has lesion in the cerebrum and how it's affecting the cerebellum or cerebellar infarct, cerebellar strokes presenting with language deficits, right? That's a very well known fact, but it's just not documented well. Yes, yeah, if you talk to your neurologist and ask them these questions, if you have a case, just ask them, and they will find, if somebody does a good neurological exam, they will find an explanation. Yeah, absolutely. These are beautiful papers. There are some beautiful papers, case rate reports, case series, Dr. Jeremy Schmann's work, which talks about all that. Yeah, absolutely.
So Bethlehem has asked something on what you ended with, that if they want to read further on this topic, is there any one or two articles or chapters that you would recommend on this?
Yeah, there is a lot of more. I can send you guys a reference list. I maybe should have put it on the last slide. Some of the papers I've shown on my slides are the ones which I have read. Again, this is a tough topic. I
जोरवर
started
कर.
working on it a few years back because I was organizing a session for ISMRM, and you would not believe it was such a difficult thing for me to find a speaker on cerebellum, right? And the great, all these great speakers, they were busy at the time, and then I had to end up doing the talk myself, and that's where I learned the most, because there are very few experts in the world, and who have done a lot of work on cerebellum. So it is a little bit forgotten organ in that sense. Unfortunately, there is no one article, but these are all good articles which I've put in my slide. Maybe I should some way put it on a slide and send it to all of you guys eventually.
So Satish Nagar is asking, can you explain cerebellar decussation and how do you differentiate it from infarct on diffusion?
Yeah, so that's a good question. I have been asked so many times on diffusion weighted scans. Anybody shows you a scan of a 60 plus year old person with a little bright signal in that midbrain region, in that area, that is your cerebellar decussation. And they are usually bright, a little bit bright. They're not abnormally bright. Typically they're not infarcts. Many times I've seen some reports also where they have mistakenly called acute infarcts. So look carefully, especially in older patients. They're always a little bit bright on diffusion. Do not call them infarcts, right? They're always a little bit bright. The COVID case I've shown you, they were exceptionally bright, and we still don't know why they were. There are few cases every year we see where there are exceptionally bright superior cerebellar peduncle fibers. I've started to put that in my report and say I don't know why this is. But if you talk to the neurologist, like in that particular case, you can see the patient had ocular findings which were reflecting of a disease process in that region. We just did not know why it happened. But to go back to your question, yes, diffusion weighted images, you will see a little bright spot in that region, in the midbrain, and that is not an acute infarct. Do not call it an acute infarct. Just remember to look for that deposition. Yeah.
Okay. And Tapas has just asked a question. Corticospinal tracts also look bright in DWI like cerebral decussation. What's the
No,
reason?
that's just the diffusion changes. Just how the tractography works, right? The water diffusion is happening in a particular direction, and they could be a little bit bright. Yes, absolutely.
Someone has asked, how long does it take to develop atrophy after an insult? Cerebellar
So
atrophy insult.
yeah, that's again a great question. I don't think I know the answer. Inferior olivary degeneration, for example, we see it a few weeks to a few months after the injury, right? I think the structural atrophy, it will take a few months to develop, just to appreciate the volume loss. The functional atrophy, the functional disconnection, you will see on PET MR, for example, or CT perfusion very quickly, right? But you may not be able to see the structural changes just because they might not be visible enough. They might not have enough volume to be seen with naked eye. Yeah, I really don't know the answer, but my guess is a few weeks to a few months.
And a follow-up question again by Kavan is, I think he's going to take up hodology for sure. Lots of questions from him. Should we suggest follow-up imaging for cerebellar atrophy monitoring? Would you suggest follow-up just to monitor atrophy or to look for atrophy which is emerging?
Yeah, absolutely. If the patient has clinical signs and symptoms, if you cannot explain everything, what is happening, usually if you talk to the neurologist, they already know, right? But yes, they again to document cerebellar atrophy, no doubt, you can ask for a repeat exam in 4 to 6 months or something if you really want to document. Many of these cases I've these are retrospective cases. So I'm reading a case done, and I go back and I say, wow, the cerebellar atrophy was not there 3 years ago or 4 years ago, and now it's visible, right? That's how these cases are collected. Some of these.
So, I mean, this was just phenomenal. I think a lot of this was eye-opening session, I would say, for many of the attendees, including me, that there's so much else that we can see and appreciate if we just have to look for it and know the underlying pathway.
Yeah,
So thanks
absolutely.
so much for this wonderful talk. And, I think a lot of people are asking for more sessions from you, Dr. Jain.
Absolutely. Happy to do that. Happy to do that.
We'll
Anytime.
probably have a session which will force you to read some more as well.
Absolutely. Oh, good to see everyone. Yeah. Thank you. Thank you for logging in. Yeah.